I'm so excited to have the privilege of introducing our next panel, Staff with Integral Care, which is a local mental health authority serving Travis County. Our next panel is going to focus on how Integral Care has used population health data to inform data-driven changes to their service delivery model. Alex Villarreal is the program manager for Integral Care's ANEW clinic, which provides services to individuals in the reentry process. He also oversees the mental health bond program, which provides alternatives to incarceration for individuals identified as having mental health needs. Mr. Villarreal is a trauma-informed, person-centered, licensed professional counselor, focusing on crisis intervention and trauma, severe mental illness, and career development. Woot woot to the licensed professional counselors. Brittany Whittington is the population health administrator for Integral Care and has more than 8 years experience at Integral Care as both a clinician and administrator. In her current role, Brittany uses analytics and population profiles to identify at-risk patients and provide targeted interventions with the goal of supporting high-quality outcomes that allow our clinical systems to thrive in an environment of value-based, accountable reimbursement. Laura Wilson-Slocum has worked for Integral Care for 16 years, contributing to their substance use disorder services, psychiatric crisis services, and crisis intervention training for first responders. Laura serves as the vice chair for the Capital Area Council of Governments Criminal Justice Advisory Committee. Along with her team working in mobile crisis response, Laura received the NAMI, John, and Kitty Holman Award in 2016 and was the recipient of the Senator Kirk P. Watson Public Service Award in 2018. She has presented her work at numerous national and state conferences, including the American Association of Suicidology and Journal of Emergency Medical Services national conferences. With that, I'll turn it over to you all.
Thank you. Thank you, Dr. Harvey. Good afternoon, everyone. Want to start off by thanking those of you that have stuck around this long to hear our presentation this late on a Friday afternoon. And hello to all of you at home who are live streaming with us. Want to thank the Judicial Commission on Mental Health for selecting our presentation to be shared with you all today. And I also want to thank you for the work that you do to improve the lives of people who live with behavioral health disorders that find themselves interfacing with the judicial system. Finally, I want to thank Dr. Harvey for her leadership, and I want to thank TCOME, or Texas Correctional Office on Offenders with Medical and Mental Impairments, for funding the program that we're going to be talking about today. I've seen April Zamora in the audience, and I know that she's presenting later today. So April, thank you to you and your organization. We could not do our work without your support. Okay, I'm gonna grab the clicker and we're going to get started. Okay, so we're going to be talking about data that we have used, specifically population health data that have informed programmatic changes with our TCOME program, which is called ANEW, and we'll be talking about that in a few slides, more about the ANEW clinic. So a little bit about Integral Care. Integral Care has been around for over 50 years. As Dr. Harvey said, we're the local mental health authority and intellectual and developmental disability authority for Travis County. And we work to serve both adults and children who live with substance use disorders, mental health disorders, and or intellectual and or developmental disabilities. So our vision is healthy living for everyone, that everyone that we serve and everyone that lives in our catchment area of Travis County deserves healthy living and has the potential to have healthy living. And our mission is we're working to improve the lives of people who live with behavioral health disorders and or intellectual and developmental disabilities. Wanted to give a little bit of insight on how this project started, how this population health analysis project started. And it really goes back to 2020, when our executive management team made an amendment to our 2020 strategic plan because of two primary events that really impacted our country and impacted the world. The first was the global pandemic, the first in our lifetimes. And the second was the murder of George Floyd. We've included the amendment to our strategic plan here, and I want to take a moment to read over it with you because it's so critical in understanding the genesis of this population health analysis we did for this program. So significant events of 2020 are impacting communities at every level. The global COVID-19 pandemic brought about rapid change that no one could predict, and its full impact is still unknown. Recovery is anticipated to take years, and of course we know almost 2 years in that is certainly proving to be true. On the heels of the pandemic, our nation experienced a renewed call for equity and justice for people of color after another African American was killed by police. A clear and urgent next step forward is to eradicate institutional racism and structural inequities. So how do we actualize that? A lot of people talk about their willingness to engage in these types of activities, but a lot of people, well-meaning people, sort of stop at that, and it doesn't really amount to anything concrete or anything measurable. So one thing that our agency has done to actualize that amendment to the strategic plan was the formation of an ad hoc board staff task force on racial equity, consisting of 3 of our board members and 3 of our staff members. And the way this particular project got started is that ad hoc committee asked our population health administrator, Brittany, to provide an analysis on our justice program that had been around the longest, that was the most tenured in the agency, and served a specific slice of the justice population, those on community supervision, living with a severe mental illness, and having significant psychosocial needs. So Brittany immediately knew the Takumi ANEW program was going to be the program that was the subject of this analysis. So just a little bit about the ANEW program before I hand it over to my colleagues, Brittany and Alex. As I mentioned earlier, the ANEW program is funded fully by Takumi. It's a large program consisting of 21 or 22 full-time staff that serve individuals in Travis County who are on probation or parole, and specifically on a specialty parole or probation mental health caseload. A smaller part of the population they serve that we're not going to really focus on in this presentation today are those who are also being served by pretrial services that are eligible for what we call our mental health bond program. On our side of the house, that is fully funded by Takumi as well. It's a really innovative program. We could spend an hour talking about that program, but it is an aspect of our new program that focuses on those that are in the pretrial phase and out on bond, in addition to the clients we're traditionally serving through the ANEW program, which are those on specialty probation and parole caseloads. To give you an idea of the size of the client population it serves, in 2020, this program served 1,417 unduplicated clients. The types of services ANEW provides are mental health support for adults. This program is for adults only, not children. And the services can include mental health assessment, mental health testing, certainly medications, assistance in obtaining prescriptions that are written through this program, life skills training, psychosocial rehabilitation, assistance with housing, and assistance with employment. And Alex is going to talk more about the therapeutic services that the project has started to provide following Brittany's population health analysis. With that, I'm going to hand it over to my colleague, Brittany Whittington, who is our population health administrator, to talk about what she found when she analyzed the population that ANEW served in fiscal year 20.
Hi everyone, I'm Brittany Whittington, and as Laura said, I'm the Population Health Administrator. So my role is really to try and give insight into our different programs on who they're serving in terms of just the population, any trends that we're seeing, any health disparities that we might be seeing within that population, just really help them understand their program better. So I come in and I actually look at our client data and I try and provide some summaries and insights into that population. So we started off by looking at the demographics of ANEW and who they are serving. The majority of individuals being served by ANEW are on parole, followed by probation and pretrial services, just to give you an idea of who they're serving. We also break down who they're serving in terms of race and ethnicity, and this really will help guide us later on in terms of looking at health disparities. What we found is that ANEW is serving a disproportionately higher number of Black and African American individuals as compared to our general integral care population that we serve on a day-to-day basis, giving us some insight into who's engaged with that criminal justice system, specifically at integral care. We also take a look at who's being served in terms of their housing status, because this also helps guide a lot of the work that we do at integral care. And what we found is that about 1 in 5 individuals served by ANEW are literally homeless and unhoused as of the time of that assessment. However, this number is likely much, much higher because 43% are at the Austin Transitional Center, meaning they are housed for now, but likely upon release, they will also, they do not have a shelter to go to. They're likely going to be unhoused, and so we really have a much likely a higher number of homelessness individuals served by this program. We also take a look at the type of diagnoses that our clients have within this program. 99% have a mental health diagnosis, 57% have a substance use diagnosis, and 49% have a chronic medical condition, while 1% have an intellectual or developmental disability. Particularly with substance use and the chronic medical conditions, these numbers are much higher than what we see in the general integral care population. As Laura might have mentioned, we served about 30,000 people per year at integral care, whereas ANEW represents 1,400 of those clients. When we're talking about diagnosing, we also look at co-occurring conditions. So this would mean they have a chronic medical condition and a substance use disorder, or a chronic medical condition and a mental health diagnosis. And we look at the prevalence of those co-occurring conditions within the population. So what we saw is that there's a higher rate of co-occurring substance use disorder, higher co-occurring rate of chronic medical conditions, and in fact, 31% of the population served by ANEW had a medical diagnosis, substance use diagnosis, and a chronic medical condition. And less than 1% had all 4 of the diagnosis categories that we looked at, so IDD, medical, substance use, and mental health. So we're dealing with a pretty high level of intensity when we're looking at those diagnoses. The number 1 diagnosis of the clients served is schizophrenia. The number of individuals served with schizophrenia is 2 times higher than the general integral care population. And we have a high rate of post-traumatic stress disorder within our overall client population, but it's much higher within the ANEW population, so higher rates of trauma within that population. So this just kind of summarizes what I said, but the number 1 diagnosis being schizophrenia, second most common diagnosis, PTSD, and then high rates of co-occurring substance use disorders and chronic medical conditions. So now we take a look at the health disparities that we found within the population. So the reason schizophrenia diagnoses come into play in this analysis is that we've seen historically that there's an overdiagnosis and misdiagnosis of schizophrenia, particularly within Black and African American individuals. And when we compared non-Hispanic whites to Black and African Americans served by ANEW, not only is there a general high rate of schizophrenia in that population, but there's a much higher rate within our Black and African American population served by ANEW. There have been a number of studies on implicit bias that have shown this overdiagnosis and misdiagnosis to be occurring when you're comparing for the symptomology of these different populations. Again, you're going to see an overdiagnosis and misdiagnosis, and this is something that we wanted to look at. When also looking at disparities, we also did an analysis to look at who's being more likely to be served by ANEW and therefore engaged in the criminal justice population. And we found that Black individuals were almost 2 times more likely to be served by the ANEW program. When looking at the racial disparities that we are seeing within the ANEW program, we also looked to compare this against our Travis County data and found not only did we have a higher rate of Black individuals in the ANEW program, but Black individuals also disproportionately represent the jail bookings that we're seeing in Travis County. So even though 9% of the total population is Black, they represent, I think, 33% of all jail bookings at the time of this analysis. We are also lucky enough to have access to the booking and arrest data for the clients when we did this analysis. And so we looked to see what are the type of offenses that the individuals in our services were being charged with. And what we found is that white individuals served by ANEW were 1.7 times more likely to be charged with a drug or alcohol crime. And then we looked within that to see the specific type of drug or alcohol crime. And what we found was that when it came to the specific type of drug or alcohol-related crime, Black individuals were almost 5 times more likely to be arrested for manufacturing and distribution compared to our non-Hispanic white population. They were more likely to receive the lesser charge of possession of a controlled substance. This came into play because past literature has shown that even though non-Hispanic whites are 40% more likely to deal drugs, Black individuals are more likely to be charged for this. And again, this is the data that we're seeing within our 1,400 strong population at ANEW. And I'm going to pass it over to Alex to talk about how we use this data and what sort of action we took to address our findings.
Thanks, Brittany, for that. So yeah, we definitely have, it was evident that it took a lot of time to analyze and get this data together. So we really wanted to make sure that we were doing something with it and not just getting the data and not having any form of follow-up. And so we got together and really wanted to plan a project that would be influenced by Integral Care's mission, vision, and strategic plan. And we really wanted to just address a lot of these findings. And this is an ongoing project, so we're still actively working on updating some processes and kind of developing the program a little further. So the first thing we did with the data was identify any gaps in the information we had available in order to make sure that we're properly tracking that information within the program level and trying to figure out if there's any additional tools that we can use to better track data. So that involved a lot of collaboration within program staff and really having changes in everyday processes to kind of start gathering some more data. And it also took a lot of collaboration with internal parties such as our MIS team, applications developers for our electronic health record, and also collaborating closely with Tacoma Compliance Monitor to kind of get some training and more information on how we can access some of the records on the TCJ side. So that's something that we've been really working on, improving our capability of gathering data. As Brittany mentioned, some of the findings were kind of on a broader level than what could be addressed within the program. So we really wanted to kind of communicate the findings and collaborate with our criminal justice partners. And so currently we have a quarterly meeting scheduled where we have jail staff as well as leadership from parole, Travis County probation, Travis County pretrial, and then leadership from Integral Care that works with the criminal justice population. So we meet on a quarterly basis to just collaborate and make sure that we're all on the same page, provide updates about specific programs. And so we had our population health administrator, Brittany, present the findings to this group to just kind of open up the space and just figure out how we can collaborate together to address some of these findings. And it was a very powerful session because we got a lot of feedback, and it really was a big drive for this project. One of the points that we addressed immediately after was there was a lot of feedback around kind of wanting to improve or increase the collaboration between the direct care staff and the supervising officers. And so what we did was we had our legal counsel do a presentation on Chapter 614 of the Health and Safety Code and just kind of discuss continuity of care and just how we can kind of collaborate and make sure that it's in the client's best interest and that we're all able to kind of maintain that communication and kind of improve on that. And so I found that pretty helpful myself because kind of seeing everyone asking the questions and collaborating was pretty helpful. Another group that we really wanted to show this data to was the actual program staff. So the case managers, counselors, prescribers and admin staff within the TACOMI program. And so we really wanted to open up the space, not just to talk about the findings, but to get some feedback from staff on how we can improve our processes and kind of what role we can play as mental health providers to kind of address some of these issues. We also kept in mind that a lot of individuals within the staff were also having their personal experiences around everything that was going on. So it was very powerful as well to kind of try to support them in balancing, providing support while also getting their own support. And so we just really wanted to get some feedback from them around work culture, identify any training needs, and just really figure out what we can do as a program to improve our processes. And so, some of the feedback that we obtained was requests for additional training in certain areas, such as trauma-informed practices, substance use resources, and housing resources. And so, based on that, that was kind of correlated with some of the findings from the actual population health analysis, considering we did have a high prevalence of individuals experiencing homelessness, as well as individuals with co-occurring substance use disorders. And so one of the initiatives was having leadership from the housing department come and present to the team and provide training on available resources and things such as rental assistance programs, vouchers, and just give them different options that they can utilize to better support clients. We also encourage staff to kind of start sharing success stories with each other and trying to really share those resources that are out there and maybe not readily accessible. On the substance use side, we also had leadership from Integral Care from the substance use programs come and provide training on actual substance use diagnosis and how that could actually play a role in maybe some of the misdiagnosing of schizophrenia, since some of that can be substance-induced. They also provided information to the case managers and counselors on available resources, both within the agency and outside the agency for inpatient and outpatient treatment. So that was one of the first things we did to address that substance use disparity there. The other thing that we did for that was that we had we kind of increased the accessibility for tobacco cessation products for our clients by having those available at the ANEW clinic instead of having them go to the pharmacy or having to go elsewhere to get those. And so, as Brittany mentioned, that was the third highest diagnosis for our population, so we knew that we needed to address that. On the disparities regarding the high percentage of individuals diagnosed with schizophrenia and schizoaffective within the populations of Black and Hispanics, we were really wanting to address that on a program level, since that is something that we actually have some control over, and that's something that we really had to check our own bias and see kind of what we're doing, what we can do to kind of address that. And so we started implementing some additional screening tools, such as the Adverse Childhood Experiences Screener and some quality of life surveys, in order to really get a better picture of what was going on with the clients and figure out if some of the symptoms may be correlated with trauma or substance use. We also started this project where we began to reassess the diagnoses of some of our clients by really having the counselors and case managers collaborate with our prescriber and with our criminal justice partners, and just really advocate and provide some additional collateral information. Outside of that, we also increased access to historical records for both of our prescribers and licensed clinicians. That way they would get a good, thorough picture of what was going on with the client before they presented to us. Part of the data that Brittany presented on showed that PTSD or any trauma-related disorder was the second highest for our population. But after doing those adverse childhood experience screeners, we found that it was significantly high and an area that may be possibly lacking. A lot of the focus is usually on meeting basic needs for our population, and that's definitely our first priority. But there's also that inherent need to address that childhood attachment trauma, and so we really wanted to just expand our services to kind of provide some counseling services that are more trauma focused, including EMDR, which is eye movement desensitization and reprocessing, DBT, dialectical behavioral therapy, and expressive therapy such as Santre. As some of y'all know, therapy can be pretty expensive. In Austin, the average rate is about $150 for a 50-minute session. Now, if you have some counselors that have these trainings on EMDR and have certifications, they're more likely to not take insurance, do private pay, and kind of up their charge. It's just not really accessible for the general population, and for our population that's just coming out of prison or jail and that are struggling to even meet those basic needs financially. It's just something that wasn't accessible. So we really wanted to make it accessible by providing the training to internal staff and making sure that we're offering that to the clients that do have their basic needs met and that are wanting to do some of that trauma work. We also revised our anger management curriculum to kind of reflect more updated research and kind of be in line with different concepts around interpersonal neurobiology, motivational interviewing, cognitive behavioral therapy, and to make sure that we're, using the best practices when helping our clients. I thought it was pretty helpful to also provide that support and training to staff, because that kind of, I feel like it's kept the staff motivated and really wanting to try out new things. And based on that survey from the data that we received from the staff survey, a lot of them were reporting really enjoying the aspect of supporting clients and helping them process some of those traumas and really make some changes there. So that was pretty helpful. We're also giving staff something to take with them as far as, having their own training certifications that they can use moving forward. And it's been pretty helpful to just kind of see how the staff have collaborated with each other, staff cases during our ongoing consultation groups, and really implemented some of these things like pretty quickly after we started the program. To address the disparities in the medical issues, we really wanted to track what was going on during sessions. So we used some quality indicators. And as y'all can see here, we provided counseling on nutrition, physical activity, tobacco cessation, and we started kind of tracking the referrals that we're making to primary care providers, since that was, a huge need that was identified. And so we just really wanted to address the medical component, since, it's all connected. On that piece, we also worked with our Integral Care's Director of Medical Analytics, who will be developing a process and training to have emergency medical kits available at the ANEW clinic in case there's a medical emergency, having our medical providers being able to kind of address that as needed. We also created a workflow to allow program staff to directly refer clients to our wellness services. So that includes personal training, dietitian services, and tobacco cessation therapy that's outside of our program, but just added as an adjunct service to the services that they're currently getting from us. So yeah, a lot of this is still in the works. We're really excited for to really see the data that will kind of let us know whether or not this is working and really kind of adjust things as needed. We'll definitely keep providing trainings and collaborating with community partners, with our stakeholders, with staff, and getting feedback from all these parties and from clients to figure out what we can do better as a program to just continue advocating for clients, increasing training opportunities, and collaborating with our criminal justice partners and stakeholders. And overall, just to be in line with Integral Care's mission and vision, we just want to really advocate for healthy living for everyone, and it really starts with us. So I appreciate y'all. Thanks for your time. Do we have time for questions? Okay. Does anyone have any questions or any comments on what we just presented on? Yes.
How did you evaluate for that childhood trauma or incident or whatever it was? How did you evaluate for that?
Yeah, so there's a screening tool called the Adverse Childhood Experiences Screener. So it's ACE for short. And it's just pretty much, a screening tool. I believe it's 10 questions that would just give us a score. And it really assesses that trauma from pretty early on in childhood. And there's a lot of studies that will show that actually impacts the future as far as higher rates of incarceration, higher rates of divorce, medical conditions, and it really does play a role in a lot of different areas. Thank you.
Hi. Can you hear me?
Yes,
Yeah.
Thank you.
You could probably hear me without this. So this is fantastic. I mean, the wealth of data that you have is just great, and kind of the focus on the data analytics. Also really intriguing to find that prevalence of PTSD and then how you've shifted to really focus more on attachment. So my comment is, and I've been thinking about this, we've been talking a lot about parental incarceration, parental substance abuse as an adverse childhood experience, right? But we haven't talked about parental mental illness as an adverse childhood experience. And so, when I think about mental health courts or the work that we're doing, it's like, how do we move it to be family focused? How do we start incorporating services to the children, whether it's TBRI or some other interventions? What are some of your thoughts on that?
Definitely, yeah. I feel like that's a very good point. We're actually part of the, this project. It's really ongoing, so there's a lot of like little pieces to it that we weren't, that aren't quite as developed, and we're still kind of in the works. But there's some probation caseloads, for example, that have like, I believe, family violence charges. So we're actually working on a curriculum and kind of to have some sort of program for those caseloads to come through us and getting some of that skills training focused on parenting and kind of, anger management around that piece. And so we're really collaborating with leadership from probation to really screen and figure out what clients, would be a best fit for this. Tacoma also does have a juvenile program where they, provide similar services, but to individuals under 18. And so we do collaborate closely with them.
Right, but this would be more focused on the family.
Okay.
I guess my other follow-up
Gotcha.
question, maybe two follow-up questions or comments, is, jail in-reach programs where we actually go into the jail and provide services to parents that have children that are incarcerated. Because how do we use that opportunity, again, to mitigate the adverse effects of having a parent in the jail?
Yeah.
And maybe the other comment is, because we talked a lot about evaluation and cost savings and really thinking, because, these services are expensive. But I always think, if you're able to keep a family together, not only are you saving hospitalizations and incarcerations, but you're also potentially saving the fact that CPS has to intervene in that family's life to take care of that child. So, kind of that challenge, when we think about, if we do this comprehensively, our cost savings are there.
Definitely, yeah, that's a great point.
So-
Yeah, thank you for that feedback. And,
You can add all that data.
yeah, no, I appreciate that. And, one of the things that we're working on is kind of specializing our process or skills training groups a bit more to where we'll have some that are like for pain management, some that are for like, specific to women's trauma, safety care type of thing. So we are, that's a good idea, having one specifically for parents. Family is definitely very important and something that is definitely a tool and a resource for a lot of our clients when it comes to housing and just getting, even as a motivation. Unfortunately, we do have a lot of clients that don't have that support, so we do have a lot of like one-on-one kind of skills training and kind of problem solving and exploring of what resources are out there. And we also have a lot of like internal resources within the agency that we may be able to refer to, such as a YES waiver program or the Child and Family Services. If we do identify that maybe someone has a kid at home or that they're struggling with that, then we're able to kind of provide that referral. And, it's pretty helpful, but, we have a lot of different programs, and usually we'll connect with someone like in the Child and Family Services leadership side so they can tell us what smaller programs they may benefit from. But definitely the family work is definitely valuable, and we do see a lot of, parents coming advocating for their children and kind of working with them as well. But yeah, it's great feedback. I appreciate that. Any other questions or comments? Okay. Awesome. Well, thank you, everyone. Appreciate your time.